What are the common overuse injuries and endurance athletes? And we're going to cover these: patellofemoral pain syndrome, iliotibial band friction syndrome, medial stress syndrome. Nice words. Achilles tendinopathy, plantar fasciitis, lower extremity stress fracture. Next slide. Okay. Let's see. What are some of the factors that are responsible? Training errors are the most common cause. Okay. Rapidly progressing your program too soon, okay, or increasing duration or frequency too soon, returning back to sport activity after an injury too soon, and trying to make up for lost time. Research shows that people who run more than 20 miles a week are at higher risk for developing this is the at-risk population, okay? Anyone running more than 20 miles tend to have more risk of developing overuse injury. Next. Okay. As I stated earlier, proper technique is critical to avoiding overuse injuries. Changes from form may be a culprit. Someone may be trying something different. And here's where the athletic trainers, teachers, therapists, and coaches play a really critical role in really preventing recurrent overuse injuries. The one thing I want to say with overuse injuries is that one of the biggest problems is that many times the tissue damage occurs subclinically. You know what subclinically means when I say that?
Not enough to show up as a problem.
Well, you won't feel it.
Right.
So in other words, you may not know that you have the problem yet the tissue is being damaged and maybe someone grabs you the wrong way and says, oh man, that hurts. But anyway, subclinical means that you do not know that you have that problem. But literature shows that patients have microscopic damage going on and they may not even know it. So that's really an important factor when we're dealing with training volume, intensity, and returning back from an injury too fast. So I just want to highlight that real quick. Next one. Okay. Obviously, some people are more prone to injuries than other people. Okay. There's anatomical and biochemical factors that you may not be able to really account for, but basically imbalances between strength and flexibility around certain joints predispose to injury. Body alignment, knock knee, bow legs, unequal leg lengths, flat or high arch feet are also important. Great studies have been done with military recruits. Why? Well, you have a captive audience, you have the military, and they're going through training. They're going through a repetitive type of training. They studied 454 military recruits pre and post, boot camp, right? And when they examined them, they were looking at foot and ankle anomalies, and they were able to successfully predict people who were going to have overuse injuries just by looking at their feet and ankle. In other words, they had pes cavus, hyperpronation, pes planus deformities, etc. So when they identified these certain groups of people, what they did was they fitted these groups of people with inner soles, orthotics, or something to correct that problem. And there was a dramatic difference in that group between the treatment group and the non-treatment or placebo group when they went through the camp. And that group that had the orthotics or the treated underlying problem did not have the problem or did not develop an overuse injury. The other one, imbalance between strength and flexibility. Hamstrings tightness. In another research study, they looked at hamstrings tightness in military recruits and found that, and again, these military studies are very good because they do it's a prospective study, and they studied hamstrings flexibility. And they took the one group through hamstring stretching, strengthening, etc., and they were less likely to develop overuse injuries again. So those are important facts, and those are prospective, excellent studies that were actually performed. Next slide. Okay. And this goes into weak links that I was talking about just a minute ago with the hamstring tightness. You may have a weak link due to an old injury, incomplete rehabilitated injury. Many times in my field, in my practice, I get many athletes or weekend warriors like myself who went to their family doctor. They got the initial pain under control. They treated them, injected them, whatever. However, again, they didn't rehabilitate the problem, so they're more likely to re-injure themselves. Other factors include the type of running shoe, terrain, hard versus soft surface, running, etc. Next slide. Okay. Usually diagnosed through history and physical. I mentioned this earlier, how and when the symptoms occur, the timing, location of pain is important to help diagnose the problem, prior treatments and previous injuries. It's usually best done by a sports physician. These are either physiatrists or family practice doctors or orthopedists who have a specialty or subspecialty in sports medicine. And usually these doctors, they have also added specific training knowledge in these types of sporting activities that we all participate in. Sometimes x-rays or special tests are needed for diagnosis, like MRIs, etc. Next slide. All right. I'm going to go back to this again a little bit later, but what is the treatment? As I stated earlier, overuse injuries of tendons usually degenerative rather than inflammatory, and as a result, they resolve slowly and seldom improve with anti-inflammatories. Rest is really the fundamental treatment. It's really dictated by the severity of the symptoms. Obviously, avoid activities that are painful. Use alternative exercises to return to sport-specific activities. So if you're a runner, going to swimming or cycling just to be able to hopefully maintain your fitness. The problem with cortisone injections, again, is that because we're not dealing with an true inflammatory condition, we're dealing with a degenerative, they may not help, or they may have just a short-term relief. I use cortisone injections really only if, say if I have a patient in therapy or rehab program and they're just too much pain really to progress in their program, or they're just having too much, they're not sleeping at night because of the pain. Well, sometimes you may have to intervene in that case. Or they're going through therapy and they're refractory, they're still not getting better. Then sometimes I would use a cortisone injection. So I use it really specifically if they're not really improving. But you have to be careful because they can result in rupture of ligaments and tendons. Next slide. Okay. If the symptoms are minor, really just cutting back for a short period of time usually is enough. Really adopting a cross-training schedule, hard, easy workout schedule, really to do other activity to maintain your overall fitness while you're recovering. And it's really important to treat the symptoms early, okay? I can't stress that anymore, because once you let the disorganization and the abnormal healing process, it's really just an abnormal healing process where that tendon become degenerated, the healing process is a lot longer. Next slide. Okay. Obviously working with the coach to assess your appropriate training is also very important. A coach that knows you, knows your training style, and paying a picture attention to warming up and icing after activity, especially if you have a problem area. Okay. Next slide. That's just general information. Let's see. I think there's a repeat slide, so we can go ahead to the next one. Okay. Patellofemoral syndrome. I'm going to talk a little bit about each of these more common ailments that endurance athletes have. This is hallmarked by anterior knee pain right underneath the patella. It can exacerbate by running, jumping, cycling, pain on climbing or descending hills. Usually pain, they'll tell you that walking flat surface or level surfaces does not cause any problems. They have a positive theater sign. You like to sit on the last row because when they sit with their legs bent, they have to extend their knees. That's what a theater sign. Next slide. Usually, again, this is some of the treatment. We kind of talked about this. NSAIDs, like I said, there's a role mainly for pain, but it's not going to speed up recovery. Icing, activity, relative rest. I like, when I refer to therapy, more of a patella tracking program, short arc quads, isometric straight leg raising. I like closed chain type of exercises like squats, wall squats, and things like that. Obviously, cyclists should undergo fitting, make sure that there's nothing wrong with their equipment, the seat height, step height. Patellar taping and knee sleeves are helpful in maintaining tracking of the patella until the underlying condition resolves. Next slide. What are some of the physical exam findings? What I'm looking for is patellofemoral malalignment. Usually what a J sign is called is when I have the patient extend their knee, their patella literally would track laterally and back, almost like a J. They have tenderness along the patellofemoral facets, pain with patellar compression. They have crepitance with active extension. Next. Usually I'll order a special x-ray called a sunrise view, and sometimes you'll see a lateral tilt over the patella. It looks like it's a ice cream cone sliding off the cone. Yeah.
What is crepitus?
That's that grinding that you may hear. You know, popping is something different. Popping, just like, well, I won't pop this morning, but that's just in the synovial fluid. The actual crepitance is something where you actually are compressing the kneecap. You actually can feel underneath, and you can feel crepitance. What's interesting about crepitance is if you do an appropriate strengthening program, that actually can go away and get better. Usually for this particular problem, the only reason I'm ordering an MRI is if we've done everything appropriately, then I'm looking for something a little bit more severe, like what's the basketball player Odin? He had an OCD lesion. See, these guys are jumping, and but basically he had a bad lesion underneath the kneecap, which is like a divot in the cement or a pothole that they try to refill. So I'm really looking for something that may need a surgical correction, but for this particular problem, you usually don't need an MRI. Okay, next. Okay, what causes runner's knee? Kneecap is located too high in the knee joint. You see that sometimes on x-ray. You see this more in females. Weak thigh muscles, especially the vastus medialis, tight hamstrings, tight Achilles tendons, poor foot support, feet rolling in and the kneecaps are being pulled outward. Excessive training overuse. Next slide. This is an anatomical slide. Basically, what I wanted to show you, there are a couple things here. First of all, these are all the muscles that help support the kneecap, okay? You see the vastus lateralis and the medialis, and then you have the rectus femoris. If you notice, anatomically at the rectus femoris, right, and the vastus lateralis, the rectus femoris actually has more of a lateral attitude, okay? The vastus medialis is the smallest muscle in that group, and so that vastus medialis by itself, and you've seen runners, they have this huge lateralis, and you have this tiny teardrop-shaped muscle on the inner side, and then you have the rectus femoris. So the rectus femoris and the lateralis are kind of pulling this way, and you have this tiny teardrop-shaped muscle keeping it medially. That's why vastus medialis training and reconditioning and strengthening is so much important. Another one, and we're going to talk about this in a minute, but there's a muscle here that's not really shown very well. It's not shown. This is the iliotibial band. I'm going to talk about that later. That's the iliotibial band right here. And you can see it crosses over the femoral condyle. So just remember that. I'm going to talk about that in a few seconds. Okay. But anyway, so you can see that anatomically, structurally, the vastus medialis is at a disadvantage from these larger muscles. That's why vastus medialis training is a hallmark in patellofemoral syndrome. Next slide.
Do you see less runner's knee in triathletes versus pure runners?
Because easily because of the but as long as they're not